Hey everyone, welcome back today. I'm going to share a really interesting case I saw last week in the casualty. 85-year-old male, known case of hypertension and CKD, who's on dialysis, brought to casualty in unresponsive state since morning 6 a.m. He arrived at around 10 a.m. and when we checked his vitals are pulse rate is around 100 beats per minute and BP is around 200 by 100 millimeter of mercury and SpO2 is 97% and respiratory rate is 20 beats per minute and CBG shows low. And remember, this patient is non-diabetic. So the first question that comes to your mind, why would a non-diabetic CKD patient develop hypoglycemia? Let's think through this step by step. First, initially in casualty, we have to assess airway breathing circulation. Since he was unresponsive, so we intubated him for airway protection and gave IV dextrose immediately. After stabilization, we started working up the cases. The major mechanism for hypoglycemia in non-diabetic patients are due to one is reduced glucose production, two is increased glucose utilization, and three is excess insulin-like peptides activity. So now in CKD, renal failure, hepatic. Now in CKD, the kidneys lost the ability to perform gluconeogenesis, which normally contributes about 20 to 25% of glucose production during fasting. Also, kidney helps clear the insulin from the blood. Nearly 1/3 of the insulins are cleared by kidney. So in advanced CKD, insulin stay longer in circulation and glucose production falls. The final result will be spontaneously hypoglycemia, even without diabetes or insulin use. In hepatic failure also the same mechanism goes on. Gluconeogenesis is impaired, so there is no new glucose production in fasting state, so patient will go spontaneously hypoglycemia. Then hormone deficiency. What's about Addison disease? Yes, it can cause hypoglycemia, but in this cases the BP is 200 by 100, where in Addison the BP will be low. So we are ruling out Addison's. Then next step is drugs. Always check for drugs. Certain antibiotics and antimicrobial can trigger hypoglycemia, like quinolones, clarithromycin, then quinine, hydroxychloroquine, and AC inhibitors too. These drug either stimulate insulin release or potentiate insulin effect. Then alcohol. Alcohol will causes depletion in the glucogen storage, so it causes no gluconeogenesis, so it will be causing the hypoglycemia. Thiamine deficiency also stops pyruvate from converting acetyl CoA. This pyruvate dehydrogenase needs co-transport as thiamine. So thiamine deficiency will indirectly affect the gluconeogenesis, so it will cause us hypoglycemia. The second heading is glucose utilization. In sepsis, particularly in malaria, the malaria parasite itself in the blood will cause us hypoglycemia by utilization the glucose, plus the treatment for malaria such as hydrochloroquine will cause us hypoglycemia. So malaria plus the treatment for malaria is a deadly combination for producing hypoglycemia. Then third heading is increased insulin-like peptide. It is also known as non-islet cell tumor causing hypoglycemia, which is retroperitoneal sarcomas, liver tumors producing IGF-2, which is insulin-like growth factor 2, will exactly act like insulin and causes hypoglycemia. These are the causes for hypoglycemia in non-diabetic patients. Once stabilized, here the workup to look the causes. You have to send RBS, insulin and C-peptide, random cortisol and ACTH with the stimulation of ACTH, LFT, RFT, rule out infection by sending CBC, CRP, malarial parasite, peripheral smear for malarial parasite, review the medication, and finally, if the hypoglycemia is recurrent, go for CT abdomen for seeing insulin growth factor secreting tumors. Management, we will 25 dextrose, plus if the patient is alcoholic, give thiamine supplement along with the 25D dextrose, monitor the patient and educate about the signs of hypoglycemia. Thanks for watching. If you found this case useful, follow for more real case discussion like this. See you in the next one.